Hi again.
Showcase my medals.
We're gonna wait for a
I had
little.
to switch seat. I had to glue the other seat. Go, go.
Hi.
Hi, Mommy.
Hey.
Do that. Go.
I'm recording.
Okay.
Okay. Hi.
Yeah. Hey.
How are you?
Good. Good. I think I have you on both here. I have you on my phone and also this. So let me stop this one. Can you guys hear me okay? Stink six.
Yeah. Nate, can you hear me?
I can.
Okay. So I'm recording this. Do you want to wait for a couple minutes for Nancy, or you want me to just get it going, Nate?
Let's see if Nancy actually shows up. Let's just wait a couple minutes.
Okay. How are you doing?
Recording. Right?
What's that?
How are you doing?
I'm doing okay. You know, it's pretty encouraging from San Diego. You know, we have at one time 20 cases that are positive, excuse me. And, you know, half of these guys are intubated on a ventilator. But for the most part, we're doing okay. You know, nothing close to New York.
Yeah. You know, and I feel like I'll get into this later, but I don't feel at all on par with what's going on like in San Diego, because we have now, how many positive cases do we have here, Nate?
We have 900.
Yeah.
Almost 1,000.
In the city or?
spread out throughout the state.
Oh, the state. Okay. Yeah. I think from a state level.
It's still, but I mean, there's been breakouts on the reservations and things like that. So it's, you know, I think that the largest count of positive cases obviously is going to be in Bernalillo County, which is Albuquerque and our largest city in the state. And then the second largest city, which is Rio Rancho, you know, that's where the next tier, we have 100 and some odd cases. Bernalillo has like 200 and some odd cases, but I mean, overall for the state, 1,000 is really not that bad.
1,000, I see. I think for us, I have a graphic. You know, I'll send you guys this graphic right now. This may be interesting for you guys to see because, well, you know, both of you guys are familiar with California.
Yeah.
So let me send this to both of you now. Is that okay?
Of course. Send it. All right. Well, let's go ahead and we'll just get started. And I'm sure when she jumps in, the owner of our company, Howie, is Nancy
Mhm.
Oriola, and she was going to jump in just to,
Okay.
ask some questions. But I'll just do introductions because since I'm sharing this with our senior community and also, just all over on all of our websites, they may not know who Nathan and I are. So I'm the director of marketing for Decades LLC, and as well as our sister company, Aging Life Care Management. And Nathan Gabaldon, he is our director of clinical services for Decades LLC, as well as Aging, well, not so much on the Aging Life side. And then we have Dr. Howie Tran. And so Howie, you are and I talked to you about your title. So you're the Advanced Heart Failure Cardiologist and Assistant Professor of Medicine at UC San Diego Sulpizio Cardiovascular Center.
That's right. You got it.
Also, so the reason why I asked you to do this, and I'm so thankful that you agreed to this and giving us your time, is that I get a lot of emails from our care management clients as well as their families, and even from nursing facilities, assisted living facilities, on like, what do we do? Is this really going to be done by April 30th? What kind of mask should I be using? What does ventilation actually really do to me? And these are just questions that are above my pay grade. Even though I have personal experiences with being ventilated, I can't give that medical opinion like someone like you. So I asked our clients, and I'm sure, Nathan and I both have questions as well, but I asked our clients, what do you want to know, from somebody who is versed in all things ventilation and respiratory issues and cardiovascular issues. What do you want to know? So I think I'll just jump into it if that's okay and start asking you a couple questions.
Absolutely.
Cool. So one of the biggest questions that I've been getting from, especially our immune compromised clients, is what are the long-term effects of being on a ventilator? I can tell them, like I said, from a personal standpoint, what it feels like to be ventilated, but I'd like to get your opinion on what are the long-term effects.
Yeah, so that's one of the I think that's one of the questions that you'd be able to answer from a personal standpoint. I was never ventilated myself, so that's where I would turn to you from a personal perspective.
Mm-hmm.
Most of the patients that are coming in that we had seen early on in China and Italy as well too, primarily those two countries, is that if you don't intubate these patients early, then they have worse outcomes. And a lot of that has to do with the ability of this virus to cause a viral syndrome or a viral infection. And that happens with most of the viruses that you see, but this is a virus that we've never seen before. And what I mean by that is that it's a novel virus. We believe that it's from a bat to another intermediate host, and then ultimately to humans. So our body isn't set up to see a virus like this. And whenever that happens, we tend to have an inflammatory or immune response that is extraordinary. And that's why you see these patients with even regular lungs have intense amounts of mucus and secretions that they can't get air into their lungs and then into their blood, because that's super important. So early ventilation strategies is something we've started to do, and we took our cues from China and in Italy as well too. So when you place somebody on a ventilator, you're dependent on the ability of that ventilator to offer positive pressure, that is air that's going into the lungs, to really open up the lungs as well too, to try to oxygenate. We find invariably these patients who have COVID, they don't oxygenate well. You may hear the terms hypoxia, which is a measurement of oxygen in their blood, and that could be very low. Some of these patients we see who are hypoxic into their 60s and 70s when normal is greater than 94%. So that's why we ventilate these patients pretty early on too. We have other strategies as well too. Every hospital has a strategy to deal with ARDS. That's acute respiratory distress syndrome. And that's when both sides of the lungs just go crazy. They secrete a ton of secretions and you can't get oxygen as well too. So instead of keeping them supine all the time on a ventilator, we would keep them upside down as well too, just make it a little bit easier for air movement and also fluid movements as well. The second part of your question is our immunosuppressed patients. Yes, we're very concerned about our immunosuppressed patients. Not only the transplant patients that I take care of, but also patients who are older, patients who've had comorbid issues like hypertensive disease, are diabetics, patients with coronary disease as well too, patients with kidney disease, and ultimately patients with autoimmune syndromes as well too, patients that are already on immunosuppression for lupus, for rheumatoid arthritis, scleroderma, immune syndromes like that. So those are the population that we're very concerned about because number one, they lack the immune system to deal with the virus to begin with, but their immune system is a little less predictive once they get the virus. Now the terminology that you guys may read about or hear about on television is COVID-19, right? COVID-19 describes the pulmonary process. Anybody that has that pneumonia has COVID-19. One can have the virus, which is SARS-CoV-2, and not have COVID-19. So it's early ventilation COVID-19 patients. So patients who carry everybody in the umbrella of SARS-CoV-2, a fraction of those patients have COVID-19 pulmonary processes. Most of those patients are older. Most of those patients have comorbid issues. But as you see in media, we've had a fair amount of cases of patients who are young as well too.
Yeah, we of course I'm terrified. Being immune suppressed, it's terrifying. But we do have a lot of our clients who are just simply healthy, 72-year-olds, 73-year-olds, never had any type of immune issues at all. Are they at higher risk just due to age? Or, yeah,
they are.
Just due to age? Okay.
Yeah, they are. And this may be important for our clients as well too. The first known big outbreak in America was actually in a nursing facility in Washington State. And it really ripped up that population and really high mortality as well too. And at that time, we didn't have any testing. We didn't know what we were dealing with. Kind of heard through the grapevines of what they were going through in Asia and then in Europe. But one of the first outbreaks we had was from a nursing facility in Washington State. And the reason is because these patients tend to be older. These patients tend to have comorbid issues. That's why they're in a facility as well too. And that is our most vulnerable population. And oftentimes there are many patients that interact with each other. It could be that many patients share the same room. And it could be a common room that they all share as well too. So a lot of interaction, a lot of contact as well too in facilities like that. That's why we're very, very worried and very careful about nursing facilities, rehab facilities, nursing homes.
So this is kind of an interesting question because we do go into homes. We're not going into homes right now. We can't see our clients. We're doing, Zoom and FaceTime and stuff. But a lot of our clients have named us in some type of legal capacity as whether it's durable POA or healthcare. Some have a family member that is one and we're the other. Well, this client, or this is actually a family member, her other sister's in the ICU. The outcome doesn't look good. She does have COVID, but they need to get into her house to get her paperwork. How long do they need to wait to go into somebody's house who tested positive?
Usually about 14 days or 2 weeks if they're asymptomatic. Okay. So I assume that this person is in the hospital.
Yes.
And she's been in the hospital for X amount of time. And since the time that she's left home, usually about 14 days or so, we would assume that it'd be safe to go home. Now let's take a step back and talk about, well, she's not there anymore. Right? So she's not there to spread the virus anymore. Right. So why 14 days? Well, sometimes you get data left and right about how long these viruses live on tables and fomites. That's what fomites are. So these viruses can be spread in a couple of ways. They can be spread by direct contact in terms of coughing on somebody or coughing on your hands and shaking somebody's hands and that person touching their face. That can be spread that way as well too. But sometimes if there are times when one can cough on a doorknob or a table and some bystander comes by and touches that doorknob or rubs their hand on the table, they can get the virus as well too. We know that the virus can live about 3 hours roughly, dependably outside of the human host onto some surface. So that's what we call fomite transmission, as opposed to respiratory transmission. There's also reports of fecal transmission as well too, but we don't know much about that in that virus particles in stool. And that's not to say that we're touching stool all the time, but it's anybody that's having a bowel movement that isn't washing their hands carefully or enough, and then shake somebody else's hand or touches somebody else. That can be the fecal to oral transmission. So in that particular case, to be the safest of safe possibilities, 14 days, but you can make a case for 3 days.
Okay. All right. So we keep on hearing the date, April 30th. April 30th, we're going to get back to normal. Everyone can go back to work. Are we opening up too soon? I mean, is it just like April 30th, it's gone? Go today,
Yeah, that's a good question. I think we've had various dates that have been placed out by whether it's the federal government or the state governments who have said it's by this date that I really want everybody to get out and really resume normalcy. What's going to be interesting is, and I really subscribe to what Dr. Anthony Fauci believes, he's one of the guys that's heading the task force, is that this is going to be a new normal for us. We don't know what this life is going to be like after this pandemic. Usually when you have a huge pandemic like this and the world suffers like this, there's going to be a new normal. That is to say, you can't blame people for wearing masks at April 30th or May 1st or Cinco de Mayo, because people are going to be out in crowds wearing masks if April 30th is going to be the time. I believe this is going to linger. I believe that as you flatten the curve, the whole idea of flattening the curve is so that you can take all those cases and then spread them out, right? So if you're flattening the curve, you're flattening the line and extending the duration of people coming to the hospital so that hospitals won't be overwhelmed. So I think April 30th may be arbitrary, and it may be a situation where we're going to see more cases into May, into June as well too. And unfortunately, this is the type of virus that, the questions are there so many strains of this virus that are out there too. It doesn't have to have so many strains. It's potent. It's done a very good job of infecting humans. So whenever viruses don't have, or bacteria don't have a lot of resiliency from a human host, it doesn't need to mutate. Right. So I don't think there are a lot of strains out there. I think what will happen, because it's so effective in infecting humans, is that we're going to start to see a lot of coronaviruses when fall hits and all that as well too. So that's when we start talking about what are the vaccines that are going to be available year after year. Not only a pneumonia shot and a flu shot, but potentially a coronavirus shot too going forward.
And I think that's an excellent segue to one of the questions that I had. This virus is here. It's not going anywhere anytime soon. So are we looking at more of like you said, we are looking more of a vaccination annually type of thing, like that of the flu? The fall comes around and then you'll ultimately get your flu vaccine. And that's pretty much what we'd be looking at with the presence of COVID-19.
Yeah, I think so, because, and that's a good question, Nate, because it's so effective. This virus is having a grand old time. And when we first looked at the virus, and for your audience who don't know me so well, within our transplant community, we're a very small community. So Dr. Adler, who's our program director, and myself, we've had meetings with both physicians in Shanghai, Beijing, and also in Milan. And we've had these meetings since January. And if they're all Zoom, obviously, and there are research collaborators in China and Italy and Germany. And what we found is that their experiences had primed us. We were the ones, actually, Eric and I were the ones who really rang the bell pretty early on in the transplant community here at UC San Diego. And Eric has since started a Facebook page as well too about this. I think this is such a devastating virus, and it's having a great time. We thought initially, well, it's just like the flu. People are going to get it. People are going to die from it. People are going to recover from it. But what we found is that this is so much more transmissible than the flu. It's so much easier to get this coronavirus if you have somebody that's close by. And this really racks up and wrecks the pulmonary system as well too. We're lucky in America. Most of America, we're pretty lucky. We don't see the mortality rates that we usually do see in Italy and Milan, and also in Wuhan in China. So I think we're lucky that way. I think we've had the shot across the bow for quite some time from both of these countries. So this virus is very effective, and with infectious viruses, just like influenza, I think we will need to get a vaccine. This is a world where, we've seen this virus. We see this virus, but our bodies have never seen it before. I think a lot of that is because it's an RNA virus, and it's coming from two different organisms that we've never seen. It's very similar to what you guys had seen back in 2002, 2012. It's interesting how these things repeat itself every decade or so. Yeah. But back in 2002, we had the SARS outbreak, right? And that was an avian flu. That was a little bit different, that outbreak was the first coronavirus that we had seen, and that's why they call it SARS-CoV-1, and that was back in 2002. And then we had back in 2012 MERS, which is more of a Middle Eastern virus, a coronavirus in the Middle East. But what do these three viruses have in common is that it's what we call zoonotic. They're not common viruses that are just because a human's passing on to humans. It jumped species. It went from one species to an intermediary species to a third species, us. And because we've never seen it before, this immunologic response is more of the thoughts ripped apart, because we've never seen RNAs like sequences like this before. We've never seen protein like this before. So we're reacting the way that we do. Our bodies are reacting the way that we do. So yes, so that's sort of a long answer to your question as to whether we may have to deal with a vaccine later in life with this.
I mean, since there is no clear treatment for COVID-19, yeah. Rather than the respiratory therapies, the ventilators, I know that they're messing with some of the malaria drugs. I think it would be helpful for people to understand. Is there any indication in regard to why the virus behaves the way it does in certain people? I know that you have a group of people, 9 out of 10 of those people experience minor symptoms. Let's say all 10 of these people have no pre-existing conditions. But that 10th person, even if they're young or old, they catch it bad, they end up going to the ICU, they end up passing even with a ventilator. Is it just the aggressive nature of this virus, the randomness, if you will, of how it attacks the immune system, or that immunoresponse, especially people with upper respiratory issues like myself? At first I did hear, I was like, oh, it's just a virus like the flu, pretty much like everybody else. And then I started seeing the list of people that were included, and I was like, oh, people with asthma are on this list. Mm-hmm. I've had lifelong asthma. Mm-hmm. It's gotten better as I've gotten older, but it's certainly kind of lit a fire underneath me to be a little more precautious. Yeah. I was already being precautious with Amanda and her immunosuppression, but I went one step further once I found out that I was on the list. So are there any indicators as to why this virus is, I guess, worse in others than it is for some other? I mean,
yeah, that's a great question, Nate. At this point, we don't know. I think what we do know is that, going back to what we were talking about previously, is that patients with pre-existing conditions and patients with comorbid issues tend to do worse. We also know, and this has been the hot topic this week as well too, that there seems to be some racial discrepancy as well too, some ethnicity discrepancies, and the big social divide as to how this virus attacks as well too, and it speaks to the social economics within America. But I can tell you that from a standpoint of who is at risk, unfortunately, both of you guys are at risk, and both of you guys obviously with different types of conditions that can put you at risk for this virus as well too. And you're right, in a population of 100 people, 98 will get the virus. They'll, a fraction of these patients may feel as though it's the worst thing they've ever experienced. The great majority will say, no big deal. Many will be asymptomatic. But the 1 to 2% will die from it. And as of now, the younger guys, what scares me is that I get on this Facebook page that Adler created, I get stories all the time of young physicians losing their lives, being in the front lines, young nurses losing their lives, being in the front lines without pre-existing conditions. So that's really scary to me. But that what we don't mention oftentimes is that being in the front lines is very stressful, and that can play a big role in one's immune system as well. So in that situation, it's stress or the burden of taking care of patients being in the front line play a big role into this too. And I suspect that there is, but we don't know yet. I think retrospectively, we're going to take a look at it in terms of all of our patients that have been tested positive, all of our patients that have responded the way that they have with the pulmonary complications and with cardiovascular complications. We'll take a look at it as to the reason and try to draw a conclusion as to why it happened the way that it did. We don't know it just yet.
So with that being said, I know that a lot of our clients, professionals as well that aren't in the medical field, I think the CDC guidelines, individual state guidelines can be confusing. So obviously, if you suspect you have COVID-19, you want to get tested. You want to self-isolate from your family. But what are the steps that one can use to determine when they need help? I mean, some of the recovery says, you self-isolate, you hydrate, you can take OTC medications such as Tylenol, Pedialyte, Gatorades, you would treat it as if you got the flu. But at what point should an individual, regardless if they have a pre-existing condition or if they don't, at what point should they go one step further to seek medical attention?
Yeah, that's a good question. I think that fever and cough are very common. So if one were to have fevers and cough, and they have had some sort of interaction with somebody that had upper respiratory, lower respiratory illness as well too, you ought to think about it. I think there's a lot that's being written right now about at what point do you go in. I think for us at UC San Diego, we recommend that shortness of breath. That is the inability to think, the inability to be able to get a deep breath in the way that you normally do. When that happens, you should go in, you should get tested and whatnot too. Here in California, what our governor has been able to allow for us is that anybody with fever and cough, all you need to do is to call your PCP. And with the suspicions there per their PCP, then they'll get a prescription to go get a drive-by swab. So we'll go into a drive-through, and that drive-through will get you into a tent, and the patient will be swabbed. And then within 24, 48 hours, we'll know what the results are. Now, that's different because as of today, if one were to go to our ER, we can know the results in half an hour to 45 minutes. That's the new Abbott test. So we have a lower threshold to check now, particularly in the bigger cities in California. The part of the confusion, I believe, though, is because the CDC's changed their mind a couple times. And as the CDC changes their minds, the local governments have tried to straddle the idea of, do we follow the CDC or do we break off and do something a little bit different? I'll give you two examples. But after talking about symptoms. So fevers, cough, shortness of breath, get in there. Okay. The other thought too, which is very interesting, is that this particular viral infection, and you kind of get this with a lot of viral syndromes, so it's not really new in terms of symptoms from viruses, is that one loses the taste and it's not a metallic taste, it's a complete loss of taste. And also one loses the ability to smell as well too. So one can't differentiate odors. And that's something that I think our ENT buddies have said, ENT, ear, nose, and throat buddies have said, go ahead and get that tested as well too, if there isn't a allergic rhinitis or some other allergies that one usually has. So we're starting to learn more and more about this virus and the manifestation of symptoms, but the main ones are very similar to flu. And you see charts like this out. If one has a runny nose, it's unlikely coronavirus. If one has a sore throat, probably unlikely coronavirus. One has a fever, a deep cough, a cough that sometimes you can't get out because it's so deep, and you kind of hear the bronchial motions of it as well too. Most likely it could be coronavirus or the flu, right? So that's one of the things you want to check. If you get shortness of breath, you got to be able to get it checked as well too. So those are the symptoms to take a look at. Both flu and coronavirus will cause fatigue as well too, tiredness. But I think the coronavirus will have that temperature that lags on and on and on. I have a friend up in New Jersey, and she is a pathologist, and she's had symptoms for 8 days, and she ended up getting tested on the 7th day because they didn't have enough tests, and it took 8 days to come back.
Yeah.
And unfortunately, she was positive. And but fortunately, she was self-quarantined. She was able to do so because they have a house, and she was in the first floor, and that was her floor. And her husband delivered food and all that stuff to her as well too. Not many Americans have that luxury. You don't have that ability to say, "All right, well, this is going to be your room, and we're not going to bother you." We don't have that luxury in a lot of America. And in terms of treatment, that's one of the things that you had asked me in the previous question, Nate, in terms of, well, this hydroxychloroquine stuff. This is the first part where I think is the anti-malarial drug. That's the first part that I think that the CDC, actually it wasn't the CDC, it was the FDA that did this. But we're all very nervous about hydroxychloroquine. Now, hydroxychloroquine was developed for malaria, anti-malarial drug. It's and malaria obviously is a parasite, right? It's something we use chloroquine and hydroxychloroquine to treat. We've been able to take that drug and use it in a lot of our patients with lupus as well too, because it is an immunosuppressive drug, we believe. And so lupus patients, rheumatoid arthritis patients who've been on this medication for a long time, and they were started on the medication stably. And unfortunately, what had happened was that we had seen a lot of stories. So what anecdotal evidence is basically just stories, case reports of it helping out patients in China and helping out patients in various South Korea as well too. We spoke to our Italian friends, and they said once they heard that from China and South Korea, they were prescribing it to everybody, right? And unfortunately, they didn't see that improvement. They felt that hydroxychloroquine didn't help at all. So that's the danger when you don't have evidence, is that when you don't have clinical evidence, but you have anecdotal evidence, just stories. This virus, as you pointed out, may have just inflicted 100 people, and 90 to 95% of them will have mild symptoms and get better. How do you know that they wouldn't have gotten better without that drug, right? You don't know. My friend up in New Hampshire, she didn't get that medication, but she ended up getting better, right? She was COVID positive, but ended up getting better and feeling great now, thank God. And but how do you know if she had taken Plaquenil, if she had taken hydroxychloroquine day 3, 4, or 5 or something like that and finished the course? How do you know that Plaquenil was responsible for her getting better, or it was just that she was going to get better? Yeah. That's the whole of getting an anecdotal study, right? Kind of like the case studies that we saw in China and in South Korea, and making it into a clinical study. What a clinical study is that you need randomization. You have patients that could be positive for COVID. You're going to divide them in half because you don't know if this drug is going to work or not. And you try to match the populations so that both populations match each other the best that you can. Then you give this population the drug. And then at the end of it, you compare to see if it actually helped or not. At the end of the day, if you have 94% survival here and 95% survival there, the drug probably didn't work. Okay. If at the end of the day, 98% of these patients felt short of breath, but the shortness of breath dissipated by day 3.5 or 4.5, that drug probably didn't help, right? So that's why it's important for us to get a study like that. But I get it. When we heard about hydroxychloroquine in the medical community, we were super excited about it, right? Then the FDA approved it for a a particular wording of that type of medication, and then I think 2 days ago they ended up and erased the wording of that medication. So that's where it's a little confusing. The mask is very confusing as well too. Initially, the CDC said you don't need a mask; you can just go around, do your thing, keep distancing for about 6 feet or so. And then they went back last week and they changed it as well too. And by virtue of that, that's asymptomatic. This is probably the reason why Wuhan got hit so hard, and the reason why Milan got hit so hard, and the reason why New York is getting hit so hard right now is because we have what we call asymptomatic carriers. That is to say that I was exposed to the virus, okay? I never developed COVID-19. I just had the virus. I had the coronavirus. And it's the SARS-CoV-2 virus. It's that novel virus. But I never exhibited any symptoms. There's a period that I am infective. There's a period where I can pass on this virus to somebody else. And so that asymptomatic carrier is a very important piece of the coronavirus story. Wearing a mask will protect other people from getting the coronavirus from me. And because I don't feel it, Nate, my dad may. My dad has diabetes. So my parents haven't seen my kids in a month and a half, because we're all, and I'm the index, right?
Sorry, Howie, I lost you. Uh-oh. Can you hear him, Nate? We lost him. Well, that was a lot. I will, I'll call Howie and see if we can do a part 2 to this, because I think there's so much more that we can dive into. But being that we only have 4 minutes left, we'll just cut it off here, but that's a lot of info.
Yeah.
So, okay. Well, thank you for being, oh, hey.
Yes. Hey.
Hey, kind of
Hey,
lost you there with my computer.
No, it's okay. So what we were just talking about is that maybe, next week or sometime we could do like a part 2, because I think I have so many more questions for you, but we only have like 4 more minutes. Up here.
Oh, okay. Sure.
But
Yeah.
thank you so much, and I'm proud to be a patient of yours, and I can't thank you enough for everything that you're doing for every single life that comes in here.
Recording.
I know.
You're still recording. Oh, okay.
Okay,
sorry.
good. Okay, well, thank you so much. I appreciate it, and I'll see if we can do a part 2 with you. You're available.
Yeah, I'd be happy. Yeah, I'd be happy to. It's interesting because next week is supposed to be our vacation week. It's Easter week, so I have it all off. But obviously, we're going to be at home. But feel free to let me know. I think Friday's a fine time for us, and I'd be happy to climb back on and chat a little more.
That would be awesome. Well, get some rest.
Thank you. You guys too. Stay safe, okay?
Hey, Howie, I had an unrelated question.
Yeah, please.
Well, it is related, but just real quick. There's a shortage of asthma supplies now because I heard that they're using it to treat the lungs for people with COVID-19. Is that true?
I haven't heard that. I know that we are using obviously inhalers. We're also we're using bronchodilators and everything because it's very deep. We believe that this is an infection that goes deep in the lungs. I haven't heard a shortage though. I know that that's something that our hospital's really thinking about nationwide. You think, Nate, or is it something that you guys are experiencing?
I've heard it locally. So my pharmacist had let me know. He's like, stock up on your inhalers and asthma meds now because we're running out. They're pulling them.
I haven't heard that. It makes sense to do so,
Yeah.
but I haven't heard.
Okay.
Okay.
I was just curious.
And you know, it's interesting that you asked that because I have a rheumatology friend who who right now is having difficulty getting the hydroxychloroquine to her clients and her patients because you know, a lot of the pharmacists are out, and these are patients who have been on this medication for a long time. So it would make sense that if people are thinking, well, listen, I don't have asthma, but in case I get this thing, but I'm myself on a bronchodilator or something like that, or hospitals are really using this up. It makes sense that the supply would be depleted at some point.
Yeah. Okay.
Well, I'm stocking up on meds. We should all be. We're all good.
Yeah, I don't. Yeah,
I'm the only one that runs in. I'm the only one that runs into the store now. Like Amanda just sits in the car.
I don't go anywhere.
All
right.
Yeah,
well,
but even then, I have
Okay.
a stockpile of albuterol mixed with ipratropium bromide.
Yeah.
And I'm holding on to it like gold.
Yeah, it's the doing them.
right.
Well, you guys stay safe up there, okay? We're thinking about you guys a lot.
Thank you.
Thinking about you guys. Be safe.
All right, guys.
Okay,
All right,
bye.
you take care.
Sorry.
Bye now.
Thanks. Bye.
Bye-bye.